Next case is a 36-year-old woman who has been referred to us from another liver centre. She presented 18 months ago with an adenocarcinoma of the colon, KRAS wild type T3N2M1 on imaging. She had FOLFOX chemotherapy, 6 cycles, proceeded to an extended right hemicolectomy, which was complicated by an anastomotic leak. Since then, she's been considered for liver surgery, but the other centre did not feel that she was operable. So they're asking us if we agree with that, and if so, what we would recommend in terms of liver-directed therapy.
So the first set of imaging we've got is a contrast-enhanced CT study from the 29th of September. The only disease that she has is in her liver. There's no extrahepatic metastatic disease. So she has, as we scroll through, you can see she's got bilobar metastatic disease.
Is that a cyst in the middle, or is that a lesion?
We'll come to that in a second. And more than 10 individual tumours. She has had, at the border between segment 4 and 8, there's this lesion which is a previous ablation zone.
Okay, so the other centre, yes, they've not mentioned the letter, but they said they were contemplating doing a radiofrequency ablation of one of the lesions. Would that be consistent?
So that represents that, and you can see that's right on the border. This is the middle hepatic vein here, and that's right on the border of segments 4 and 8.
8, isn't it?
You can see the extent of the disease through the liver.
So how much of segment 4 is involved?
So segment 4 appears clear on this study. The disease on the left side is there's a metastasis here posteriorly in 2, another metastasis adjacent to the stomach in 2, and there's some more further disease down in segment 3.
So that's all peripherally placed, isn't it? Nothing closer towards the portal pedicle or the left vein.
And clearly she's got quite substantially more disease on the right side.
So might be classed as borderline operable?
Yes.
But the left lobe is quite small, relatively small?
Yes.
Yeah,
in terms of what would be left as the liver.
So borderline operable as a staged procedure rather than...
Yes. So what are the surgical options, and then what are the other options?
So surgically, what we would be looking at here is to, if we're doing it as a staged procedure, an ALPS type procedure where we divide the liver along the lines of segment 2, 3 and 4 and take out the little lesions that are peripherally placed in segment 2 and 3.
Yes.
In the same procedure. And at the ALPS procedure, what we will be doing is tying off the portal vein to the right side and leaving the artery intact, but dividing the parenchyma and taking all the outflow out of the right lobe, leaving only the venous drainage into the KY intact.
Right. So ALPS is one possibility, and more traditional surgery, that would be portal venous embolization?
We would embolize portal venous again on the right side, and we could be looking at ablating the left side at the same time, and then resecting the right side, coming back 6 weeks or so afterwards.
Okay. And do you require downsizing chemotherapy prior to surgery?
I mean, it depends on how this patient will respond to chemotherapy. There's a slight risk that the patient could progress while on chemotherapy and the options be less easy.
Yes.
What do you think, Phil?
I think it depends a bit on how secure you are with that segment 4/8 ablation zone, because if that is disease free, then you're left with just peripheral disease within the left liver. If there's any worry of recurrence at that site, then treating that at your ALPS procedure is difficult because it's deep within the liver rather than at the periphery.
I mean, we've got two options. You could consider that segment 4 lesion treated and no residual disease, and leave segment 4 behind,
Yes.
and resect only the right liver. But I was thinking of taking that out because it was involved. There is a risk of recurrence.
Yes.
You have the option of having the segments 2 and 3 remaining only. So there are two options,
So
broadly
yes,
speaking.
yeah, there are two options. And the lesions on the left, would you say that they are all ablatable
I think yes, there would certainly be reasonably straightforward ablation.
with microwave?
We would use microwave, and we'd need to move. You need to move the stomach away from this lesion here, using some form of hydrodissections where you interpose fluid, and again that would normally just be in the lesser sac. You use fluid to move the stomach away from your area of ablation, so you can treat that completely.
Okay,
It'd be an
so
involved ablation, but it should be a straightforward ablation.
So in terms of downsizing and hypertrophying the left lobe, there are two options: either portal venous embolization of the right, or SIRT to the right side, which would also treat the right at the same time, and should also cause hypertrophy of the left.
So I think the options for SIRT are either in the palliative setting to treat the whole liver, although if we're thinking of this patient as being somebody who may potentially come to liver resection, one might want to spare what will become the future liver remnant, which would be the left lobe, and to confine the SIRT to treatment of the right lobe with the view to controlling the disease in the right lobe and promoting contralateral hypertrophy in the left lobe. I think the downside to that strategy is that it won't control the disease in the left lobe, which may then subsequently progress whilst we're waiting for that contralateral hypertrophy.
Would you combine that with ablating the left lobe at the same time? Is that too much?
I know. I think you could. I think I would probably be more inclined, if I were going to go down the ablative route, though, to use portal vein embolization rather than SIRT at that point, because the control of the disease within the left lobe with ablation is likely to be fairly reliable, and if the right lobe is going to be resected, then I think controlling the disease in the short term in the right lobe using a liver-directed therapy solely to the right is less of an issue.
Okay, understand. Yeah.
So when the patient attends the clinic, we'll discuss various options. We'll discuss the possibility of ablation of the lesions in the left lobe with right portal venous embolization and a right hepatectomy. That's the ultimate aim. We'll discuss the possibility of doing SIRT to the right as an alternative to portal venous embolization, and we'll discuss the ALPS procedure as a possible surgical option. Right, so we discussed this case 8 months ago, and we presented the options to the patient. The patient decided to continue with chemotherapy and had a further 8 cycles of FOLFIRI plus aflibercept. Did not respond sufficiently to that to become operable. Then proceeded to a microwave ablation done at our center and a right portal venous embolization done at the referring center. So we're now discussing this case with a view to potential operability.
So the 2 scans that we have to look at are from the 10th of October 2014 and also from March 2015. So on the top, this is a post-ablation, so it's immediately post or day 1 post-ablation, and we can see the areas that we've treated. So during the pre-ablation workup, I'm sure you remember there was this area of treatment on the border of segment 8 and 4A, and we thought that showed recurrence on the pre-ablation MRI that we did, and so we elected to treat that in addition to the left-sided lesions. So this is the ablation zone on that margin to try and ensure that as much of segment 4 was clear of tumour as possible. was
So
the
just to
view-
clarify, the patient had had a radiofrequency ablation done previously at the other centre, and while you were doing the microwave ablation of the lesions in the left lobe, you also treated the recurrence in the
yes,
right lobe.
Yes, absolutely. So, and this is the ablation zone that we created adjacent to the ablation zone that was previously performed. And then we have this confluent area of ablation treating the more lateral lesions in segment 2 and also more caudally in segment 3. Again, as part of the ablation workup, we found another small lesion in segment 4B adjacent to the falciform ligament, which we also treated. And then when we come subsequent to that to March, this is after a portal venous embolization, so we can see, and again Phil will perhaps be able to talk us to a bit more than that, but she has the high density is Lepidol, which has been used to embolize the portal vein in the posterior segments of the right lobe, and we can see mature ablation zones on the left side, which appear free of tumour.
So the question we're being asked by the other centre is the potential resectability of the disease now following those therapies.
Can I see the left hepatic vein mark and also the portal inflow?
So that's the left hepatic vein there, and that's the portal, that's the hilum there with the anterior divisions of the left portal vein.
And volume-wise, what have you got?
But I think volume should be satisfactory now that segment 4 has effectively been treated with microwave. I'm assuming that you're thinking of leaving a significant amount of segment 4. So initially 1, 2, 3 and 4 had a volume of 550 mils, and that's now 690 following the ablation and the portal vein embolization.
That should do, shouldn't it?
Yeah.
So we can offer the patient
I think so,
a
yeah.
right hepatectomy.
I think we could do.
Okay, thank you. Right, so we discussed this case in March, so that was 7 months ago, and since then the patient did have surgery as we recommended, so they had a right hepatectomy at the other centre, the referring centre. First scan post-op was clear of disease, but we've just been sent a letter saying that she now has recurrence. Just a reminder, this is a 37-year-old woman who's been quite heavily pre-treated and has had a combination of ablation, surgery, 2 lines of chemotherapy, aflibercept, and cetuximab, and they're now asking whether we would recommend either further systemic therapy or other liver-directed therapy.
So the imaging that we have to review is a CT study from the 2nd of July and a further imaging on the 23rd of December, both from 2015. And on the July study there's a post-resection and probably a seroma after the right hemihepatectomy, and adjacent to the intrahepatic IVC more immediately there's a small area of low attenuation that would be certainly suspicious and consistent with a further metastasis. Come December, that area hasn't really changed a great deal. It's probably stable.
Is it
in terms of
real,
the size.
Mark? Do you think that's recurrence?
I think it is real for a metastasis, and she's also developed an area sort of in between the 2 ablation zones, which is further tumour, and another peripheral area here in segment on the disjunction between segment, well, I presume it's 3 and 4 now. You see, there's been quite a lot of hypertrophy of the liver after her resection, so she's still got a good volume of residual or remnant liver, in which to, if we're considering any directed therapy.
So are the lesions on the current scan ablatable by microwave?
Yes, so I think certainly the key lesion is the lesion next to the IVC, and I think with the combination of microwave and the jet vent anaesthesia, so when the liver is stationary, we can then target that sufficiently to be able to safely ablate adjacent to the IVC, obviously not hit the IVC, and to ensure that there's a reasonable chance of getting a good margin. Its location is actually quite favourable from our point of view because it is below the confluence of the hepatic veins. So again, the real concern, I think, when you're ablating somebody who's had a previous resection is not so much in situ thrombus in the IVC, because that's clearly not a good complication, but if you had in situ thrombus within the hepatic veins, then there would be in a lot of trouble. And so I think we're sufficiently far away from it from that point of view that as long as we can treat the other lesions completely, we still have a radical option which should be well tolerated by the patient.
Do you think a further surgical option is reasonable or not?
I don't think so, not with that IVC lesion.
And it's recurred quite soon after surgery,
I think
hasn't
so.
it?
She's had
Yeah.
a lot done, hasn't she?
Yeah. So we agree that surgery is not appropriate. Ablation is possible, but only by microwave and will be technically difficult. And the patient can continue systemic therapy and have ablation combined with that. And what about SIRT as an option?
I think it's technically feasible, and it would have the advantage of treating the entire liver remnant. As Mark said, there's been good hypertrophy of that liver remnant, and certainly we've treated patients with smaller remnants than this, clearly inducing radiation-induced liver disease in very small remnants post-operatively is a concern, but I don't think that's a particular concern here. But I think if Mark feels he's able to treat the disease completely with ablation, I would probably favour treating it in that fashion, although there are 3 geographically separate lesions, each of them individually is relatively small. So I think it would probably be preferable to treat each of those at this stage with ablative therapy and to keep SIRT in reserve, because of course you may continue to progress or develop new lesions within the liver remnant and may get to a point where she can't be treated with truly local modalities, and at that point I'd probably give a SIRT to the entire liver remnant.
I think I agree with that completely.
Okay, so we all agree that we'll continue systemic therapy, we will offer microwave ablation, and then if there is further recurrence following that, we will discuss SIRT in combination with systemic therapy.
Correct.
Okay, thank you.